In this lecture, we're going to focus on consciousness and coma, and then look at some common neurodegenerative diseases, including Alzheimer's. So look at the definition of cognitive disorders, coma, and syncope, and then we'll look specifically at Alzheimer's and other conditions that might contribute to dementia. So there are three types of cognitive disorders: delirium, dementia, and then disorders causing amnesia, amnestic disorders. They all result from central nervous system impairment, and they affect memory, attention, orientation, and judgment. So unlike the other conditions where we've been looking at just motor or sensory deficits, things like that, these conditions involve cognition. The mini mental state exam, which is a questionnaire, little test that patients can be put through. This is available for download online. This is a common clinical tool that we use to determine severity of cognitive disorders. So let's look at the first one here, and that's delirium. Delirium is important to differentiate from dementia. A lot of people confuse these two. Delirium is an acute change in consciousness, and the level usually of consciousness varies throughout the day. It waxes and wanes. There's usually a change in cognition, disorientation, memory deficits, language disturbance. Some patients with delirium experience hallucinations and illusions. And then very common in the elderly to experience what's called sundowning, where the delirium becomes worse at night. In the case of delirium, there's almost always an underlying medical disorder. So very importantly in delirium to be sure that we do further assessment and workup to see what might be contributing to this. So things like infection, trauma, chronic hypoxia to the brain, substance withdrawal like alcohol, different medications, toxins such as acute heavy metal poisoning, often this is seen in patients in the intensive care unit who are suffering from very severe acute illness. Symptoms usually last for days or weeks, and unfortunately there's a high mortality if the underlying medical condition isn't addressed. So this is where delirium could be telling us, okay, we got to go look further as to what might be causing this. The treatment is to, number one, rule out any medications that might be causing this. So anticholinergic medications are a common class that contributes to delirium. Correct the underlying medical disorders. Look at using potential pharmacologic therapy. This is more symptomatic, like antipsychotics. Close observation of the patient, and then limit really napping and sedation. So you want the patient to be conscious a certain number of hours a day, and then constantly reorient the patient. So these are treatment guidelines that are going to be more applicable to hospitalized patients, not so much patients in your clinic. But again, delirium, very important. This is potentially reversible. It's acute, and this is where the underlying medical condition needs to be explored. That's different from dementia, which is a progressive and typically irreversible impairment in cognition and memory. Now, about 15% of patients with dementia do have treatable reversible causes, but by far the majority, it's irreversible. Debilitating mainly affects the elderly. So 20% over the age of 80 suffer from severe dementia. And the level of consciousness typically does not vary throughout the day. So it's going to be just the same level of impairment throughout the day, no sundowning effects. Signs and symptoms generally appear gradually and progressively. And the causes are age, increased age, but most commonly it's going to be either Alzheimer's disease or vascular dementia. Those are the two most common. And vascular dementia is when there is inappropriate blood flow to the brain, and that's usually due to severe atherosclerosis. Other treatable causes would be hypothyroidism. That's a pretty common one to think about. So a lot of elderly are not fully worked up for hypothyroidism, and that is a reversible cause of dementia if that is addressed early enough. Lead toxicity, Lyme disease, meningitis, neurosyphilis, that's the tertiary syphilis, medications, and then severe malnutrition. B1, folate, and B12 are the three most common nutrients that we find. Zinc would be another one in there. But all of these could be micronutrients that are used to support a patient with dementia. Might not reverse their dementia, but might prevent further degradation. No cure unless the underlying medical condition is recognized, like hypothyroidism. So address the treatable endocrine causes, look at nutrition, as I mentioned, B vitamins, zinc, potentially iron. Palliative care, basically. There are low-dose medications for dementia. Some antidepressants are used. Neuroleptics are antipsychotic meds. And then a lot of times with dementia, there's extreme agitation, and patients feel trapped, they feel paranoid, they start to try to wander out of the room at night or their house at night, things like that. And sometimes that's where things like benzodiazepines are used to help sedate a patient. So unfortunately with benzodiazepines, that might actually make dementia and the cognition problems worse. So that's dementia. Problems causing changes in memory impairment without a loss of consciousness or other cognitive functions are called amnestic disorders, and they're usually caused by an underlying medical disorder, like history of strokes, brain trauma, tumor, very low blood sugar, systemic illnesses, seizure disorders, MS, encephalitis, substance abuse, alcohol, medication. So that would all be part of the history to try to target and narrow down what might be contributing to the amnestic disorder. There's two types of amnesia. Patients often experience a combination of both. Anterograde amnesia is the inability to make new memories that occur after a CNS insult. So you can remember up to a certain time, they had damage from alcoholism, for example, and then after that they can't make any new memories. Retrograde is the inability to recall old memories from before the CNS insult. So we can have anterograde or retrograde amnestic disorders. And then we can have problems in either procedural or semantic disorders. So procedural is remembering how to do something. Semantic is more remembering sort of basic ideas or concepts around something. So that's procedural or semantic disorders. Clinically, it's helpful to differentiate amnestic disorders into either of those. So the treatment really would be here to address the underlying medical disorder. So know the difference between delirium and dementia in particular, in that they're quite different. They present differently, but they have different outcomes, and we can address different things with them. So I'm going to say a few words about coma. Again, you're not typically going to be seeing patients in a coma in your office, but it's good to know something about what this is. So by definition, it's defined as a score of 8 or less on what's called the Glasgow Coma Scale, lasting for more than 6 hours. So you can look up what this Glasgow Coma Scale is. It's basically a questions that's checking 3 areas: visual activity, voice, vocal activity, and motor activity. And there's a score of each between 0 and 6. And so Glasgow Coma Scale is a very helpful way of assessing a person who's unconscious or partially conscious, what their level of impairment is. So deep, by definition, coma is really a deep state of prolonged unconsciousness in which the person can't be awakened. So they're alive, but they can't be awakened. They fail to respond to normally painful stimuli, light and sound. They lack a normal sleep-wake cycle, and they do not initiate voluntary movement. So that's by definition a coma. Now, by definition in the medical world, consciousness is defined as a state of wakefulness in which there's awareness of self and surroundings. So wakefulness and arousal, it's the quantitative degree of consciousness that's mediated by the brainstem and the reticular activating system, if you remember that. And then awareness is the qualitative aspect of functions mediated by the cortex, so the higher brain centers. So we can look at consciousness as having 2 aspects: a brainstem aspect, which mediates wakefulness and arousal, and a higher cognitive aspect, which mediates awareness. Again, if we look at the areas in the brain, it's the reticular activating system which is mediating this arousal, and then again the cortex with awareness. And depending on what part of the cortex is injured, different parts of awareness are going to be compromised. So the causes of coma or stupor, we use this acronym SMASH to kind of help us remember all these different things. So one could be structural brain pathology, so things like strokes, tumors, hydrocephalus, herniation of the brain from increased intracranial pressure. M would be for meningitis or mental illness. A is alcoholism or acidosis. S is seizures or substrate deficiency. Thiamine, B1, is a big one. And that can happen in chronic alcoholism, depletion of vitamin D, B1. And then H for hypercapnia, high carbon dioxide in the blood, high acidity, hyperglycemia, hyperthermia, hyponatremia, low sodium, and hypoglycemia, low blood sugar, hypoxia, hypotension, and hypothermia. So you don't need to memorize all these. Again, this is just to kind of maybe trigger your memory that there is a mnemonic we can use to work through the causes of coma. Again, you're not going to be working these up because these are the patients that are going to be hospitalized. Endocrine causes, so your adrenals, if they're not secreting adequate cortisol, that can be from destruction of the adrenals from an autoimmune disease called Addison's disease. Thyroid toxicosis is excess thyroid or low thyroid. Encephalitis, encephalopathy, and then electrolytes like calcium, magnesium, phosphorus being dysregulated. And then finally, different drugs. So opiates, barbiturates, benzos, things like carbon monoxide, cyanide, methanol, all these can induce coma. So just to give you kind of an overview there. Now, there are a couple of states we need to differentiate, sort of a differential diagnosis of coma. So if with coma, alertness, a person is unconscious, there's no sleep-wake cycle, eyes are closed. We looked at the most common causes above. There's no voluntary motor activity, but the respiration continues. There is respiratory drive, as we call it. Now, if a person is in a situation where they're wakeful and alert, they have retained cognitive abilities, but they basically have only motor ability to their eyes and eyelids. All the other motor ability, with the exception of respiration, is paralyzed. And that has to do often with a problem of demyelination of the descending motor neurons in the pons. And I talked about that one before, and that's called central pontine myelinosis. That can also happen from a brainstem stroke or advanced ALS. This is what's called locked-in syndrome. So the person is fully conscious, fully alert, they have full sensation, but they have lost motor activity to most of their body. And that's again due to a compromise of the motor neurons. Like in ALS, you have disintegration of the upper motor neurons, or in the central pontine myelinosis, demyelination of those. And that's from typically either chronic alcoholism or overcorrecting sodium like intravenously too quickly, which again would be a kind of a iatrogenic cause of that. Persistent vegetative state, PVS, is a person has wakefulness without awareness. So it looks like they're awake, but they're not showing signs of cognitive awareness. The higher, it's like the brainstem is still functioning, but the higher cortex isn't doing anything. There's a normal sleep-wake cycle, not wake cycle, and the eyes are open. So it's a little disturbing. It looks like the patient's aware and awake, they're there, but they're not responding to any conscious cues. And this is usually from diffuse cortical injury, stroke, things like that. So there's no voluntary motor activity. So you ask the patient to squeeze their hand, there's no response. But there is respiratory drive still. So that's locked-in syndrome, persistent vegetative state, and coma. Brain death, patient's unconscious, no sleep-wake cycles, same causes as coma. But basically, you know, if you have a heart attack, you again lose blood flow to the brain for more than 4 minutes, you start having neuronal death. No voluntary muscle control, no respiratory drive, and the EEG essentially would be flat, so no EEG rhythms. So know the differences between coma, locked-in syndrome, persistent vegetative state. In Chinese medicine, the concept of consciousness is related to the Shen, so we would relate these as Shen obstruction disorders via different pathogenic factors like wind, fire, phlegm, heat, phlegm, damp. If we look at atheromas, for example, in ischemic stroke, we can think of that as a type of phlegm or phlegm fire. Uncontrolled diabetes would be maybe heat and damp. And then severe bleeding, like in hemorrhagic stroke, this would be more of a heat-fire condition, and or wind heat obstructing the orifices. So these are some of the names you might see given in some of the Chinese medicine texts that relate to these different disorders of consciousness. Syncope is just fainting or passing out, and then pre-syncope is like I'm about to pass out, but I don't actually pass out. The most common cause, this is the most common cause of loss of consciousness, LOS, and it's secondary to an abrupt drop in cerebral perfusion. So it's not due to some chronic neurodegenerative problem, it's just that the brain suddenly loses perfusion, it shuts down. Again, pre-syncope is feeling of intermittent LOS without actually fainting. The most common causes would be seizure disorders, cardiac arrhythmias or cardiac outflow obstruction, hypotension, low blood pressure, vasovagal syncope. This is about 50% of all cases. That's a momentary lack of sympathetic tone, so you can't maintain your normal blood pressure. especially when going from sitting to standing. So people feel pre-syncope or even faint when they stand up. And that's often related to orthostatic hypotension, low blood pressure. Less common causes would be severe cerebral vascular disease like basilar artery transient ischemic attacks, metabolic problems like severe hypoglycemia or hyperventilation, which causes that you ventilate off your carbon dioxide, you get more alkaline in the blood, hypovolemia from hemorrhage, low blood volume, and different medications might actually create sensation of syncope or pre-syncope. So the patient is going to present with a report usually from a trigger, fear, or valsalva or prolonged standing initiated the syncopal event. And then often there's a prodrome of lightheadedness, dizziness, maybe muffled sounds, constricted vision, diffuse weakness. So very commonly encountered in the clinic. See a lot of patients with acupuncture. I've had several over the years that have passed out after getting needles, and if they're sitting up, like for a shoulder treatment or something, you have to be sure that you can catch them before they hit the floor. But it's always something to be cautious of and ask patients about any previous syncopal events. Once, if this happens, if someone does have syncope, it's a good idea to get a full history, but then refer them out for a full workup to check their vital signs, to check all their basic labs like their blood count, make sure they're not anemic, check their liver and kidney function tests and their electrolytes with the complete metabolic panel or CMP. CMP again also includes a glucose, and then check thyroid function with the TSH, thyroid stimulating hormone test. And then it's always important to get an EKG, potentially with cardiac enzyme studies to make sure a person didn't have a heart attack. And then if a chronic arrhythmia like atrial fibrillation is suspected, getting a Holter monitor, which is something they wear over 24, 48 hours that records any abnormal heart rhythms, because they're not always necessarily in that abnormal rhythm. Consider an echocardiogram, which would check for the outflow, make sure there's no valvular problems in the heart, anything like that, and then potentially neuroimaging if a brain tumor or something is suspected. There's something called tilt table testing, which can check for the autonomic tone, and that would rule out other non-cardiogenic causes. And then usually structural causes, it's good to know, like a basilar artery transient ischemic attack or obstructive hydrocephalus, are going to be rare in patients who quickly return to normal consciousness. So if you pass out, wake up, nothing there, it's unlikely a stroke happened, or TIA, happened. Remember, stroke symptoms have to go more than 24 hours. Seizures would be likely candidate if you saw some sort of convulsions, some sort of muscle or limb jerking, especially unilateral, that lasts for more than 30 seconds. It's challenging because a lot of people, right before or as they're passing out, will have what looks like to be a seizure activity, and that's not abnormal. That's just a typical thing that occurs, but if that activity lasts for more than 30 seconds, then that's most likely indicating a seizure disorder. If they're having severe, like post-ictal confusion, that sort of thing after the syncopal episode, that might also suggest there was a seizure. Basically, the treatment here is to address the underlying cause. So you need a thorough diagnosis first. Why did they pass out? It's not always identifiable in everyone, and then we just kind of say, well, it's probably metabolic, you had low blood pressure, you were dehydrated. And if it only occurs once or twice, that's fine. But if this is something that recurs a lot, that needs to be really worked up more thoroughly. So that's a little bit about syncope and syncopal disorders. Now let's jump back to dementia and different neurocognitive disorders. Remember, dementia is a chronic progressive decline, most typically irreversible in patients, and it can have several different causes, the most common being Alzheimer's, up to 80% of causes, and the other most common would be vascular dementia, and that both show an abrupt decline in cognition, and usually memory and just the ability to reason, those sorts of things are all compromised. Vascular dementia is from cardiovascular disease, CVD, so atherosclerosis and so forth is very common. And one way to assess that is to actually measure with an ultrasound the carotid arteries, and often there's significant plaquing that can be demonstrated there. So that's going to cut off blood flow to the brain just in and of itself. But that also means within the brain there's probably significant plaquing as well. Other less common forms of dementia would be Lewy body dementia. This one has visual hallucinations and Parkinson's-like symptoms. We're going to look at Parkinson's coming up, but Parkinson's is associated with a resting tremor, muscle rigidity, and then sort of facial expressions without emotion, so kind of a rigid, emotionless facial expression. So we see that a pattern of that, the Parkinson's symptoms, with visual hallucinations and severe cognitive loss, and we call that Lewy body dementia. There's frontal temporal dementia, also known as Pick's disease, and that's where there's drastic personality changes or language deficits that develop in a person. Normal pressure hydrocephalus is basically when there is a problem of the cerebral spinal fluid circulation, and that can result in chronic dementia, start affecting the gait, also things like urinary incontinence. Creutzfeldt-Jakob disease, this is more abrupt decline. This is from prion disease. This is very rare, but there are cases of this. There are still tribes around the world that practice cannibalism, and eating neural tissue dramatically increases your risk of developing Creutzfeldt-Jakob disease, so eating other human neural tissue. These prions are proteins. They're not genetic material, they're not cells. Prions are just misfolded proteins, and when you ingest them, they actually are able to cause proteins in your brain to misfold, and that can induce the prion disease and dementia. Tertiary syphilis, and then Parkinson's itself, without the visual hallucinations, but Parkinson's disease can progress into dementia. There's a lot of different things, though, that can trigger dementia, so it's important in the workup for a patient that they get assessed for their endocrine function, like thyroid, very importantly, but also their blood sugar, other metabolic issues, their liver kidney function, other medications, obviously, but tumors, trauma, infections, etc. So some of these will be more associated with delirium, remember, which is reversible and it's more acute, but dementia is going to be more chronic decline. So that's all the types of dementia. Again, this is, as a primary care physician, I refer out if I suspect dementia for a full neurocognitive assessment so that we get a definitive diagnosis, and then we know what kind of treatment we need to use, because these other types of dementia really need different types of treatment versus just classic Alzheimer's. So let's look at Alzheimer's disease. This is a neurodegenerative disease characterized by progressive cognitive deterioration in dementia, declining activities of daily living, ADLs, apraxia, amnesia and selective memory impairment, and then declarative memory deficits, especially memory loss of recent events. So the short-term memory is lost. But they can remember back usually to childhood memories and so forth. And then neuropsychiatric symptoms and behavioral changes, so depression and psychosis are common as well. I should say, just going back up here to apraxia, I should really define that because I don't think we've spoken about that yet, but that's basically where brain damage causes a problem in motor planning, so planned motor movements like moving a limb, that sort of thing, are compromised. So that is also associated here with Alzheimer's. The risk factors, the biggest one is age. Very rare before the age of 60. There are certain genetic types of Alzheimer's which present at a much younger age, but typically it's after 60. There's often a family history, and females are more affected than males. Down syndrome, so patients with Down syndrome have a much higher risk of developing Alzheimer's dementia. We do also know that chronic metabolic things, for example, having hyperglycemia, basically either pre or actual type 2 diabetes, can dramatically up the risk of Alzheimer's disease as well. So that's a modifiable risk factor earlier in life. So that's why glycemic control is extraordinarily important. We think the pathophysiology involves several things. So first is loss of different neurons and synapses, especially acetylcholine secreting neurons in the temporal lobe, parietal, and prefrontal cortices, in the cingulate gyrus, and the hippocampus. So there's going to be challenges with memory and those sorts of things. There's deposition both inside and outside the neuron of different proteins. So we have beta amyloid that accumulates within the neurons, and then what are called neurofibrillatory tangles with tau proteins. This is called a tauopathy. So not important to know what those are, but basically just think of misfolded proteins accumulating inside and outside the neuron. They're not cleaned out. the normal processes that remove those are lost. And again, we think astrocytes and some of the glial cells there are participating in supporting the neurons, so we suspect there's maybe a problem in those glial cells not appropriately supporting their neurons. And then finally, there's excitotoxicity with excess or abnormal glutamate signaling. And glutamate causes, when it overstimulates a neuron, causes excess free radical damage and so forth in the neuron. So if you look at classic sections of the brain in Alzheimer's patients, and of course we can't really do this, we can use neuroimaging, but in terms of actual brain sections and biopsies, that's not done to diagnose Alzheimer's. But what you gradually see is cortical thinning. So you see the ventricles enlarging over time, but then you're losing a lot of the cortex, you lose a lot of the surface area on the cortex, and so just gradual sort of disintegration of the brain itself. The prognosis, the survival after initial diagnosis is typically 5 to 10 years from the onset of symptoms. And death usually occurs in Alzheimer's patients from pneumonia. They aspirate contents into their lungs, and that sets up pneumonia. That's called aspiration pneumonia, or other infections. So that's a very common reason for decline later in life, is this Alzheimer's. The diagnosis is by exclusion. Again, there's no definitive diagnosis. That would have to be a biopsy, which really is only done at autopsy, if an autopsy is done. There is neuropsychological testing, and that's the main diagnostic criteria. So there are different cognitive exams, Minty mental state exam, and so forth. There's a whole battery of tests that can be run to sort of assess a person for dementia. And that's typically, again, there's some debate about whether or not that's a primary care provider's role or if that should be really referred out for specialty care. I typically send out for more further assessment. A detailed neurological exam usually is pretty unremarkable. There's no motor or symptoms or signs. An MRI, CT is only indicated in patients with Alzheimer's to potentially rule out other conditions, like is there a tumor, is there a history of stroke, things like that we can visualize. No definitive labs, but again, checking metabolic derangements like thyroid, blood sugar, and B12, syphilis testing, and so forth would all be important. And so we typically do a general battery of lab tests at the beginning if we suspect a patient has dementia. And usually the treatment is just palliative. So the kind of main symptoms that develop with depression, agitation, sleep disorders, hallucinations, delusions can be addressed with pharmacotherapy. I usually start with level 1 to 3. The problem is by the time the patient presents with symptoms, they usually have a significant loss of cholinergic neurons. They have a significant cerebral atrophy. And I don't think that's reversible in many of those cases, but it's worth trying. There's a number of different nutrients. I'll mention some of them coming up here that we suspect can actually support normal brain function. So it's worthwhile giving those a shot. But we don't have the answer yet to really solving this cognitive decline. I think the most promising data is suggesting we got to work with the metabolic issues like the hyperglycemia, hypertension. Those kinds of things all can make drastic differences in prevention and hopefully decrease the incidence of Alzheimer's. The first-line therapy pharmacologically is often cholinesterase inhibitors. Remember, cholinesterase breaks down acetylcholine, so this keeps more acetylcholine around. These cross the blood-brain barrier, and so they can work centrally. So we call them centrally acting cholinesterase inhibitors. So donepezil, rivastigmine, galantamine are examples here. And they can maybe restore some of the cognitive function, but only briefly, maybe for a year or two. These pretty much become ineffective after that. NMDA receptor antagonists, remember NMDA is a glutamate receptor. This also shows some promise in slowing decline, and that's memantine or Namenda. I had a patient with Alzheimer's who had a lot of agitation, and it really wasn't until she went on this medication that her agitation disappeared. And she was actually in a assistive care facility. She was leaving her room every night, going to other people's rooms, taking out their underwear, and doing all sorts of crazy things. And she frequently tried to leave the facility, and they had to put her under special lockdown so she wouldn't do that. As soon as she started the memantine, she stopped doing that activity. So I think there's a role for it. Again, how long that is effective for, it's probably only a couple of years. So that's kind of an overview of the biomedical treatment approach. Here's just a little bit more on the Alzheimer's medications. So again, the centrally acting acetylcholinesterase inhibitors are sort of a first-line therapy. The donepezil, Aricept, galantamine, arazidine, the rivastigmine, Exelon, and so forth. And we haven't actually talked about drug names, but I should mention that, you know, the drugs are always listed by their generic name. So donepezil is the generic. The Aricept is a brand name. So the original company, pharmaceutical company that did the research, they put out this drug, it's donepezil, and they put out their patented version of it, Aricept. Well, patents usually wear off, I think it's after about 7 years for drugs, and then other companies can come in and make the same drug, and so they can make donepezil. They can't call it Aricept, but they make donepezil. So that can get confusing. We usually prefer in medicine to use the generic names because that is just the drug name itself, whereas the brand name, people are more familiar with it, but it's only that patented form that they're referring to. So galantamine, rivastigmine, tacrine are all examples of this. Now, obviously, if you keep more acetylcholine around, these drugs also act peripherally, so that could potentially increase cholinergic effects like your parasympathetic nervous system activity. And so nausea, diarrhea, vomiting might be potential side effects there, even muscle cramps. And we know tacrine is associated with hepatotoxicity, so patients have to be followed with liver function tests. So that all raises the idea, like, are there naturally occurring acetylcholinesterase inhibitors? And actually there are, and many of these are classified as nootropic agents, which are cognitive enhancers. So galantamine itself, interestingly, is a naturally occurring alkaloid from the Caucasian snowdrop. And there's also red spider lily, rosemary, and sage. All of these contain natural acetylcholinesterase inhibitors. In the case of rosemary and sage, if you inhale the oils, they actually pass into the brain and have effects there. So we actually have clinical studies showing people inhaling rosemary oil actually can, with dementia, have some improvement in their memory outcomes. Ginsenosides in the ginseng, Panax ginseng, this is a acetylcholine reuptake inhibitor and receptor enhancer. And then there's some question about endocannabinoids or the cannabinoids activating endocannabinoid receptors in the body, improving memory. So these would be some potential natural acetylcholinesterase inhibitors that could be tried. Memantine, I mentioned, is an NMDA receptor antagonist, and it blocks the glutamate activity, so hopefully slows the rate of memory loss in Alzheimer's patients. Pretty well tolerated, few side effects. There is a natural equivalent here, and that is known as huperzine A. This is a type of alkaloid found in Chinese club moss, Huperzia serrata. And this is an NMDA receptor antagonist and acetylcholinesterase inhibitor, so it does both. And it actually has a few clinical trials that have shown benefits on cognition and memory, and it's sold over the counter as a dietary supplement. So a lot of these supplements for cognition and so forth often have huperzine A in there. And then another approach would be just to give precursors for acetylcholine in general. So choline, so to make acetylcholine, the body needs choline, and it needs acetylcarnitine, and it needs vitamin B5 as cofactors. So these are sometimes added to supplements, to the thought being that you absorb these, they get into the brain to some degree, and they can upregulate acetylcholine synthesis. Okay, so that's a little outline of neurodegenerative diseases like Alzheimer's. We also looked here at the difference between delirium and dementia. We looked at coma and syncope, and it's important to always think about this when any patient presents to your office with a change in consciousness or a change in memory.